Dr. Tanner is an associate professor in the Department of Internal Medicine, Division of Oncology and Hematology. Dr. Tanner's clinical focus is GI cancers, predominantly liver, gastric, and colorectal cancers. Dr. Tanner, you may take over the screen now.
Great. Can you all see my slides?
Yes.
Super. Okay. Well, I want to thank Dr. Lin and the planning committee for inviting me to talk today. I'm going to be talking about the anal cancer therapies in the metastatic setting mostly. So I want to give you kind of an overview of the talk here really quickly. We'll kind of review and be familiar with the current standard of chemotherapy for metastatic anal cancer. I also want to review the role of immunotherapies in anal cancer. And if we have some time, which we'll see if we do, we'll discuss a little bit about some of the concerns for disparities in the treatment and cancer care in anal cancer. So I'm going to start historically and then move to kind of the big reveal, which Dr. Kashnik has already alluded to in her excellent talk. So I want to give you some of the background of where we've been and kind of where we're now going. And of course, I'm sure a lot of you have heard that 5-FU cisplatin used to be the gold standard, and I want to share with you the data that was backing that up. As you can imagine, as you heard from Dr. Kashnik's study, we're talking about 9,000 patients, and of that, only about 13% of those patients are metastatic. So when you do these kind of clinical trials, it's very hard to get this kind of data to be able to drive what we do in the metastatic setting. And this is one of the earlier studies from 2014 by Dr. Ng. This was again, single institution, so MD Anderson study. It was retrospective. And so, we're looking at this kind of data for driving some of what we do in the metastatic setting for anal cancer. Small study with 77 patients. And they compared 3 different kind of regimen buckets, I would call it. So they had the 5-FU cisplatin, which 55% of their patients retrospectively had received, carbotaxol, which about 31% of their patients had received. And then they had this third bucket of just this multidisciplinary treatment where they could have maybe done liver resections, lymph node resections, or RFA, all kind of into this little third bucket, which about 14% of their patients had. So again, 70% were females, which we're not surprised at, looking at the epidemiology data of who typically gets this kind of cancer. And 67% of the patients had received prior curative intent chemoradiation. So at the end of the study, they looked at progression-free survival, and they saw that there was 8 months for the 5-FU plus cis versus 4 months for carbotaxol. And again, because of the numbers and the retrospective data and everything, this was not statistically significant, but I think a lot of people interpreted this as a pretty good sign that we should continue with 5-FU cis as kind of our first line in the metastatic setting. If you look at the multidisciplinary management bucket, though, they had a progression-free survival of 16 months. Again, the smallest bucket of the group, but maybe some localized therapy could be beneficial. Then we had in 2018, so 4 years later, Memorial Sloan Kettering said, well, let's publish what we do. This again was a single institution retrospective review looking at kind of their practice and wanting to get that data out for people. And their regimen of choice was full cis. So they looked at 87 patients, again, retrospective single institution, and their regimen was cisplatin at 40 milligram per meter squared day 1, leucovorin 5-FU bolus, and then 1,000 milligram per meter squared per day of the 5-FU. This was a 14-day cycle. And then they kind of looked at that and they just compared it to this bucket of other regimens, right? Again, we're dealing with small numbers of people in this small setting, so this is the kind of data we're looking at. So their result, progression-free survival, was 7.1 months with an overall survival of 22.1 months for their regimen of full cis in their retrospective review. And when they looked at their bucket of any other kind of regimen, the progression-free survival was 6.4 months with an overall survival of 17.2 months. So, I mean, so again, we could say, okay, full cis is an option, right? I mean, this is not, prospective. This is not randomized, any of this kind of stuff, but this is just kind of informing some of the practices. So again, we're looking at the 2018-2019 realm. What I'd like to show though is what they looked at in terms of toxicity on their study. And I've listed here your grade 2, grade 3s, and grade 4 toxicities. And yes, there were grade 4 toxicities with full cis, but look at the numbers on the grade 3 toxicities, 20%, 25%. So, I mean, there are significant toxicities associated with these chemotherapies. And when you're working in this palliative realm, right, where you're telling patients, I can't cure you, but I can give you some therapy to treat you, toxicities become a big deal, right? We want to try and give them something where they not only have extended life, but also good quality of life. So then we started looking again, this was around the same year, 2018, when this was published, at a regimen DCF. We finally have a multi-centered study, so not just one institution, but it was a single arm phase 2, at least it was prospective. And what they were looking at is doing 6 cycles of DCF, which is docetaxel, cisplatin, 5-FU, versus a modified DCF with 8 cycles. And again, the DCF normally is a Q3 week with some pretty hefty doses of chemotherapy. The modified would be a 2-week regimen with some dose reductions in that. So you're talking about docetaxel at 40 as compared to 75, a cisplatin of 40 as compared to 75, and then of course your 5-FU. So it's just basically looking at one regimen, but it's looking at, a heftier dose over a 3-week period versus a modified lower dose of a 2-week period. They had 69 patients enrolled, 36 of them received the DCF, 30 received the modified DCF. So we get to look prospectively, this is multi-centered, so we're starting to get into a little bit of broader data. The results here, their primary endpoint was met, which was basically looking at progression-free survival at 12 months, and 47% of the patients were still alive and progression-free at 12 months. 70% of the patients had at least one grade 3-4 adverse event. So again, quite a bit of toxicity with these regimens. And when you're dealing in that palliative care setting where you're not going to be able to cure their cancers, it's very hard sometimes to convince these patients to continue with very toxic regimens. And of those adverse events, things like neutropenia, diarrhea, fatigue, mucositis, the things that we would expect with those chemotherapies were very prevalent. So now we get to the current standard of care. So if you were snoozing a little bit, this is the time to wake up because we got some amazing data coming out finally. Unfortunately, it came out in the year of 2020, and I believe this was published in April. So I feel very much for the authors of this paper who did an amazing randomized multi-center study in a very difficult cancer to get the patients for, and they published literally a month after the COVID, epidemic was at full roar. And so I think some of this may have gotten a little overlooked, but if you missed it, I'm going to show it to you now. And this is now our current standard of care. This is carboplatin paclitaxel. So this was an international rare cancer initiative, multi-center randomized phase 2 trial of cisplatin and 5-FU versus carboplatin and paclitaxel. And again, remember, cisplatin 5-FU was one of our metastatic standards of chemotherapy. So we're comparing it against the carbotaxel. If you remember to the early study where it was single-centered and it was low numbers of patients and it was a retrospective review, they didn't really find any statistical difference between the 5-FU and the carbotaxel, but the 5-FU looked a little bit better. So now we're going to do a big powered prospective multi-centered randomly assigned study, and we're going to really look at it, right? So they did a 1-to-1. They did cisplatin of 60 versus 5-FU of 1,000, 3-week cycle, versus your carbo at an AUC of 5, remember area under the curve of 5, plus paclitaxel at 80, which is a day 1, 8, and 15, and this was in every 4-week. They enrolled 91 patients, and it was 1-to-1, so 46 patients received the 5-FU cis, 45 received the carbotaxel. And the median overall survival was 12.3 months with the Cis5FU versus 20 months with carbotaxol. This was statistically significant in a randomized multi-centered trial. So carbotaxol has now become our new standard of care for our metastatic disease, anal cancer. In addition, and I feel like this is just as big, it clinically reduced toxicity in the carbotaxol arm. We were not only able to improve overall survivability, but we were actually able to give patients a much kinder regimen so that they weren't struggling so much with the side effects. So here it is. This is now our new treatment moving forward. And I just wanted to give you those toxicity grade AE profiles. If you look, the one thing is the neutropenia, where you have a little bit more in the carbotaxol versus the cisplatin arm, but everything else, the fatigue, febrile neutropenia is more in Cis5FU, mucositis, nausea, vomiting, thromboembolism, they're all much more significant in the Cis5FU arms versus your carbotaxol arms. So a much kinder regimen in terms of toxicity for patients. So this is very exciting. Unfortunately, it had to come in the year of 2020, but we're spreading the word now, right? So I also want to talk about immunotherapy. There's been some exciting studies coming out in the immunotherapy realm. We'll start with nivolumab. So nivolumab, this was a study for previously treated unresectable metastatic cancer. And again, we're doing, trying to do these studies in these small groups of patients, but this was a multi-center single arm phase 2 study. And I really feel like moving forward, we're not going to see any more retrospective individual single institutions. We're going to need these cooperative group multi-centered studies moving forward. So single arm multi-center phase 2, it was treatment in the refractory setting. So again, they've already had first line and now we're moving into second line treatment. And this, of course, the study came out in 2017. So it was still in the early phases of the immunotherapy where we were giving a mg per kg dosing, and I'll show you a little later, we're now at kind of a standard flat rate dosing. But oops, I'm so sorry. But this was Nivo at 3 mg per kg every 2 weeks, and 37 patients were enrolled. So when we looked at the data for this, 24% of patients had a response, 2 of those complete response, 7 with partial response, and 72% of all the patients had disease control. So a very valuable and valid second line therapy in the metastatic setting after an initial treatment with chemotherapy. Median progression-free survival was 4 months on average, but the longest duration of that was 10.4 months. So we get a little bit less than a year on some patients that really are responders. Median overall survival was 11.5 months with an estimated 1-year overall survival of 48%. So we're making some inroads now finally with metastatic anal cancer, and this is very exciting, and we have options. And we have a new gold standard first line. We have some options now for subsequent therapies that, again, with immunotherapies are very well tolerated. Pembrolizumab at the same time, not to be outdone, came out with their study in 2017, and theirs was a safety and anti-tumor activity of the anti-PD-1 pembrolizumab in patients with recurrent carcinoma of the anal canal. This was Keynote 28. It was a multi-cohort phase 1B. And interesting, in this study, they actually specifically looked at PD-L1 positive tumors. So they had to have a positivity, at least 1% or greater, to be enrolled in this study. And again, we're talking kind of earlier times, they used a pretty big whopping dose of 10 mg per kg of pembrolizumab in this study. And we'll see when we look at the toxicity profile how that affected it. But they treated for up to 2 years. They had 25 patients enrolled in this study. So when we look at the results, 64% of patients experienced a treatment-related adverse event. And this is probably because of that whopping dose that they gave. Diarrhea, of course, a very well-known side effect of immunotherapies, was one of their main culprits, as well as fatigue. And so I think we do a little bit better now with giving the flat rate dosing that we do, and I'll show you that in a minute. but the overall response rate was 17% with stable disease and 42%. So overall disease control rate of 58%. Again, a great next second line option in the metastatic setting for patients after they've been treated with therapy. So let's do just a quick summary of standard of care now. You saw this in Dr. Kashnik's study. I'm going to focus in on just the metastatic disease here. Our preferred regimen is carbotaxol. This is practice changing as of 2020 from our multi-center randomized trial with good data behind it. So we're really excited now. And I think patients tolerate this much better. We still though have the other recommendation, the other regimens in the recommendation. You can continue to do the 5-FU cis. There's the full cis still here, the modified DCF, some of the earlier regimens that we talked about. Of course, carbotaxol, because of its toxicity profile and its overall survival benefit, is our preferred regimen. And then you can see kind of in your second line therapies, your preferred regimens are going to be your immunotherapies like your nivolumab and pembrolizumab. And again, with the pembrolizumab studied in the setting of at least 1% or greater PD-L1 positivity. So those are your NCCN guidelines. I'd just like to quickly direct your attention down to the bottom here at the dosing for our immunotherapies. This is something I was mentioning earlier in the studies. They did a mg per kg. Now you can see the dosing being at a flat rate dosing for nivolumab and pembrolizumab as an option. They have still maintained, however, the mg per kg if you prefer that. But look at the pembrolizumab mg per kg. They had a 10 milligram per kilogram in the study, now at the recommended dosing of 2 mg per kg, because we know it's much better tolerated and you still get great effect from it. Okay, so that kind of takes us through our different options. I do want to touch briefly on disparities. There have been some great studies, and of course, with our last American Society of Clinical Oncology meeting this last year, disparities had a big role and kind of took center stage for a lot of these cancers, as it has become a focus for a lot of us medical oncologists and ASCO in our cancer care to be aware of these things. There was a study from 2019 that I'll be briefly talking about, but just to give you a little bit of background, anal cancer accounts for about 1.5% of GI cancers and 4% of cancer deaths. These are the known risk factors, of course, HPV, HIV, smoking, etc. And we know that it's mostly in elderly women. So just to kind of give us a background. One of the studies, and this was one from 2017, looked at socioeconomic and gender disparities in anal cancer diagnosis and treatment. And this was a really interesting study because they wanted to know, did the receipt of radiation differ depending on income level and demographic factors with patients? They actually did a SEER database review and all the way from 1988 to 2011, and they linked this to an area health resource file to be able to pull all this data. They use logistic regression and Kaplan-Meier analysis to correlate the receipt of radiation, to correlate overall and cancer-specific survival with things like tumor stage, age, gender, income, to try and see if we could pull apart what was actually causing decreased access to care. Of the 28,000 patients they looked at, 17,700 had received radiation, and they found that patients in that lowest quartile for median household income were significantly more likely to present at higher stages and 1.27 times more likely to die of anal cancer than those in the highest income quartile. They also found the wealthiest patients were more likely to receive radiation within each stage group. So again, if you look at my last point, the wealthiest patients were more likely to present with lower stage diseases. And so when you just compared wealthy across all stage groups, it wasn't as significant. But when you pulled out the particular stage group and compared within that stage group, the wealthiest patients were more likely to receive radiation within each stage group. And this can then roll into some of the outcome changes. So this is something we have to be aware of and we have to be looking at in terms of trying to get patients access to care so we can improve our outcomes in this type of cancer. And then finally, I want to touch briefly on some future directions. I think Dr. Kashnik did a great job on touching on some for local disease. In the metastatic setting, we have a couple of different studies that are enrolling and moving forward. So combination of a drug called spartalizumab, I hope I pronounced that right, I don't know, with modified DCF and radiotherapy in patients with metastatic squamous cell anal carcinoma. So that's one of the studies moving forward. So immunotherapy plus your DCF. Again, carbotaxol has been our mainstay, but we're still using some of these other regimens in combination. I think this is interesting that we're trying to pull cetuximab, see if we can get some benefit of that in the metastatic setting. So cetuximab plus avelumab versus avelumab alone in unresectable locally advanced metastatic squamous cell anal carcinoma. And this is going to be, you know, a second or plus line, right? Progress after at least one line of systemic therapy. So you would assume they would have gotten the carbotaxol, and then now let's see what these other regimens might be able to provide and offer for us. There's also a phase 3 clinical trial of carbotaxol plus minus Nivo. So another immunotherapy addition, and this would be in the first line setting. So this is exciting. This might even change our practice again, our gold standard again, depending on the results of the study. And then we have a study of DCF in combination or not with atezolizumab. So you're seeing a lot of these combinations of immunotherapies now with chemotherapy regimens we have and know are effective. And then this last one, this is interesting. It's a phase 2 study of a new drug, which is an immunotherapy that targets the HPV transformed cells in subjects with carcinoma of the anorectal canal. So it'll be interesting to see what kind of benefits we might get from this newer drug that is hopefully coming to market, depending on the results. So we've got some exciting things in the pike, and that will end my presentation. I know that was a bit of a whirlwind, but some exciting things now in terms of new regimens, carbotaxol in terms of first line, and then immunotherapy in terms of second lines, and some exciting things coming down the pipeline. So thank you for your attention, and I'll turn it back over to the committee.
Thank you so much, Dr. Tanner, for your wonderful presentation. We learned so much about chemotherapy and immunotherapy from your lecture. Again, we will take any questions at the